Good evening, all. Welcome to ISA online PG class, which is held every Monday from 5 to 6:30 p.m. Today, we have amongst us Dr. Dipasri Bhattacharya from West Bengal, who shall be talking about pediatric neuraxial blocks. We understand that because of COVID, there has been disruption in teaching and training of our very dear postgraduates who have worked very hard during the COVID pandemic. For that, we have started these ISA online PG classes to ensure that the teaching aspect is taken care. That's why we're holding classes every Monday, and they have been well received. Soon we are going to start ISA skill centers, which shall be the centers of excellence to impart the training for those skills which our dear postgraduates or even our younger senior residents feel that they have missed it out during the residency or senior residency. They shall be near their place so that they don't have to travel too much. For that, we are already taken steps, and we shall be soon circulating a form for knowing the competencies which you want to acquire and those hospitals which want to impart those trainings. So we are working on the preamble of ISA National, that it is dedicated to academics, clinics, research, and social welfare of our all members. And we as a team shall ensure that whatever the best we can do for our members, we shall do it. As the National Secretary of Indian Society of Anesthesiologists, I, Dr. Naveen Malhotra, welcome to you today's class and wish good luck to you. I request Dr. Nishant to please carry forward the proceedings.
Thank you, sir. And it is a very nice initiative by the ISA leadership and especially Naveen Malhotra, sir, Venkatgiri, sir, to start these ISA online PG classes where every Monday a speaker of national repute spares his or her time to teach the students the various aspects which are important for the exam. And today is no different. Today we have amongst us Dr. Dipasri Madam, Dr. Dipasri Bhattacharya Madam. She is the professor and head of department, the Department of Anesthesiology and Critical Care and Pain, the director of the Pain Clinic, director of the FIPM course, and the COVID intensive care in charge of the RG Kar Medical College in Kolkata, West Bengal. She is the former president of the ISA West Bengal State Branch and the West Bengal SSP, and the scientific co-chairperson of the National Conference ISACon 2017. He is a former specialist board member of the National Board of Examinations and the Secretary Board of Studies of the West Bengal University, a former coordinator of Cancer Pain SIG National. He has many articles, more than 80 articles in journals of national, international repute. He's a peer reviewer of many journals of the state, national, and international level. And she has been awarded the Ambassador for Pain Management at the ICRA in 2016. Her areas of interest are regional anesthesia and critical care. So we are very fortunate, ma'am, that you've been able to spare your valuable time, and we look forward to the lecture on neuraxial blocks in pediatric patients. Ma'am, just for your information, all the viewers and audience will be muted for the course of this session. Just in case there are any questions that the audience might have, they will type it in the chat box. Just in case there are any questions that you might have for the audience, you may ask them, and then they will also type the answers in the chat box. And all the queries that they might be having, we will be discussing after the session. Okay. So this will be the plan for the day, ma'am. All these lectures are live streamed live on the YouTube channel and the ISA NHQ channel, and everybody can see it also there. So over to you, ma'am. You may start your slide shares, please.
We can mute all now.
Right, sir.
So am I audible? Can you hear me?
Yes, ma'am, you are audible, but
Okay.
your slides need to be in the full screen mode, ma'am.
I have done it. Yes, I have done it full screen.
It is not yet in the full screen mode.
No.
So you can stop share, ma'am, and then open the PowerPoint presentation in the background and then start sharing the PowerPoint.
Okay. Okay, just wait.
Yes, ma'am. Yes, ma'am. We are waiting.
All these classes are available on ISA website, isaweb.in, and on the ISA YouTube channel, ISA NHQ. And you can always go there, and those who are missing these classes can see the recordings there also.
Yes, ma'am. It is visible now.
It's now okay?
Yes, yes. It is visible now.
Okay. So a very good evening to all of you. At the outset, I thank Dr. Nobin Malhotra sir and Dr. Sahai. Dr. Nobin Malhotra, Secretary ISA National. Thank you, sir, for inviting me in this PG teaching program. And thank you, Dr. Sahai, for your kind introduction for me. Today's topic is Pediatric Neuraxial Block. Now, what is Pediatric Neuraxial Block? Neuraxial blockage causes interruption of the neuronal transmission at the level of neuraxis, that is, spinal cord, by means of local anesthetic drugs. The nerve root is the primary site of action of local anesthetic, maybe it is epidural block or intrathecal block. Now, intrathecal administration of drug is delivered directly into CSF and the superficial part of the spinal cord. Whereas in epidural administration, drug diffuses to the dura and comes into the CSF and then produces its action. Now, anything we learn, history is very important. So, pediatric regional anesthesia is very popular in everyday practice over the last 3 decades. August Bayer, who was a German surgeon, in the year 1898 introduced spinal anesthesia, and 2 of his first 6 patients were children. Meredith Campbell in 1933 first reported caudal block in children for cystoscopy. Now, Ayers from Melbourne in 1970 first studies blood level of local anesthetic in children after various doses of therapy. Now, coming to the complications of Uraxial blockage in children. The indication, main indication is perioperative analgesia and relief of procedural pain. This is the main indication. Usually, the neuraxial blockade are given as an adjunct to general anesthesia. It is also indicated to provide preventive analgesia. What is preventive analgesia? Preventive analgesia should be administered in the pre-operative period, continue throughout the intraoperative and postoperative period.
I'm sorry to interrupt, ma'am, but your voice is a little low. I think we need just a little louder, ma'am. It's not very clear. There's a hum that is coming because of the continuous humming sound. The voice is getting drowned a little bit.
Now, it's better?
A little louder, ma'am. I'm sorry to disturb you.
It's better now?
Slightly better, ma'am, yes.
Slightly better. What is the problem? I can't understand. Now it is better?
Slightly better, ma'am. Slightly better. I mean, thoda sa loud because the sound is low.
Whether I'll continue or just try again.
You can continue just a little louder, bus. Yes, ma'am.
So, now
I think there is a fan which is running. Probably that is causing the sound or something.
Okay. The fan is not running.
Okay. Please continue, ma'am. I'm sorry to disturb you.
So, what are the indications? Now it is better?
Yes, ma'am. Yeah, slightly better.
What are the indications of this neuraxial blockade? Perioperative analgesia and relief of procedural pain. This is the main indication for regional block in children. Usually, neuraxial anesthesia is given as an adjunct to general anesthesia. The other indication is preventive analgesia. What is preventive analgesia? It is started in the pre-operative period, continue throughout the intraoperative and postoperative period. What is the idea behind this preventive analgesia? It prevents development of chronic pain and it is usually administered by epidural catheter. The another indication is management of non-surgical pain. In case of post-herpetic neuralgia, cancer pain, sickle cell disease during vaso-occlusive crisis. The other indication of neuraxial blockade is chronic pain relief and palliative care. Here, continuous epidural blockage is administered to relieve vascular insufficiency in Kawasaki's disease and pain in erythromelalgia. These are two very rare diseases. Now, what are the benefits of neuraxial blockade in children? It reduces opioid consumption. Now, we all know that opioid is the gold standard as an analgesic, but it has so many side effects. It produces sedation, it produces nausea and vomiting, it produces constipation, so many. So, if we add local anesthetic to the opioid, this will hasten the onset of action and reduce the opioid consumption, reduce the dose of opioid. So, reduced opioid consumption. It reduces the incidence of post-operative nausea and vomiting, reduce post-operative pain scores. And another benefit is if pain is really reduced, then there will be better lung excursion. So, this reduces the incidence of respiratory complications and ultimately lower circulatory stress hormone level. So, these are all the benefits of the neuraxial blockade. What are the types of neuraxial block? Now, according to the position of the needle or catheter insertion, it may be caudal block, it may be epidural block. Epidural is divided into lumbar epidural, thoracic epidural, intrathecal block and combined spinal epidural block. Now, according to the method of administration of local anesthetic, it is single shot technique, intermittent bolus or continuous infusion technique. Now, what are the techniques? Can you see this picture? So, this is
yes, ma'am.
This is the epidural space containing fat, and this blue marking is the dura. So, when the drug is injected superficial to dura, puncturing ligamentum phlebitis, the epidural block. Now, what is caudal block? Caudal block is, we know that epidural space extends from the foramen magnum up to the sacrococcygeal ligament. So, if the local anesthetic administered in the caudal epidural canal by piercing sacrococcygeal ligament in the sacral hiatus, it is caudal block. And when local anesthetic, you can see in this picture again, this is the epidural space, this is the dura, this is the subdural space, and this is the arachnoid matter. So, beneath the arachnoid matter is the subarachnoid space. So, when it is injected in the subarachnoid space, it is the intrathecal subarachnoid block or spinal block. Now, what are the drugs used for neuraxial blockade in pediatric patient? Usually, they are local anesthetic drugs. Amino-amide local anesthetic are lignocaine, bupivacaine, levobupivacaine, and ropivacaine. They are primarily protein bound, 90% are protein bound. They undergo enzymatic degradation in liver, but they should be used with very caution in neonate and infant less than 6 months. And there is risk of toxicity due to reduced clearance. Now, amino ester local anesthetics are chlorprocaine, tetracaine, prilocaine. They are metabolized by plasma cholinesterase. Now, what are the local anesthetic guidelines for maximal allowable dose? For bupivacaine, for single dose it is 3 mg per kg. For levobupivacaine it is 3 mg per kg. Ropivacaine it is 3 mg per kg. Lignocaine it is 5 mg per kg. Lignocaine with epinephrine it is 7 mg per kg. Now, for continuous infusion rate, this is very important. For bupivacaine it is 0.4 to 0.5 mg per kg per hour. Levobupivacaine same, ropivacaine is same, and lignocaine 1.6 mg per kg per hour. And continuous infusion rate in infants less than 6 months, half the lower dose, half the dose. Now, what are the other drugs? The adjuvants used in neuraxial blockade. What is the purpose of adjuvant? To provide early onset of block, to prolong the duration of blockade, and it enables uses of diluted local anesthetics, especially in neonates and young infants, so reducing the total dose. But the potential reduction in incidence of LAS, so it also causes potential reduction in the incidence of local anesthetic systemic toxicity. Now, what is the recommended dose in pediatric regional anesthesia of these adjuvants? Usually, morphine and fentanyl are commonly used. They are used to epidural and intrathecal route. The dose of epidural morphine is 30 mg per kg, maximum dose is 50 mg per kg. And in intrathecal route, it is 10 mg per kg, maybe up to 20 mg per kg. In case of fentanyl, epidural through epidural route, the recommended dose is 1 to 1.5 mg per kg, and maximum dose is 2.5 mg per kg. And intrathecal route 1 mg per kg. So we can also use sufentanil, clonidine, ketamine through epidural route. What are the factors which influence performance of neuraxial block in pediatric patients? This is very, very important. In pediatric patients, what happens? See this picture. This spinal cord extends up to the level of L3, lower border of L3. This is L3, lower border of L3. Sorry, this is L2, this is L3, lower border of L3. And dural sac extends up to the level of S3. This is S1, S2, S3. Now, what happens in adult? It is the lower border of L1, the spinal cord ends, and dural sac at the level of S2. So, what is the effect? Now, as there is low termination of spinal cord in pediatric patient, there is risk of direct trauma to the spinal cord. So, when you apply an epidurals or intrathecal blockade, always it should be above the level of, not above the level of L3, below the level of L3. Now, what happens to the lower projection of the dural sac up to the ST level in case of pediatric patient? There is inadvertent penetration of the dura while giving caudal injection. So, you have to check for CSF whether it is coming out through the needle while giving caudal block. The bone is cartilaginous and the vertebra is also cartilaginous. So what happens? What is the danger? There is low resistance to penetration and direct trauma and bacterial contamination of the ossification nucleus. So short and short bevel needle should be preferred instead of thin sharp needle, and avoid applying excessive force. In pediatric patient, what happens? The axis of the coccyx changes, but there is absence of the growth of the sacral hiatus. So what happens? What is the result? Hiatus is smaller with increasing age, and this will cause identification of sacral hiatus very difficult after the 6 to 8 years of age. Now, the delayed ossification and growth of the iliac crest in pediatric patient causes Taffier's line to cross at the level of L5 S1 interspace, whereas in case of adult patient it is L3 and L4 space interspace. Increased fluidity of epidural fat increases diffusion of local anesthetic up to 6 to 7 years, and there is providing excellent quality of block. Now, there is loose attachment of sheaths and aponeurosis. So what happens? Increased spread of local anesthetic around the nerve path blocking the distant nerves. Larger volume of local anesthetic is needed for epidural blockade because of the leakage along the spinal nerve roots. Now, CSF volume as a percentage of total body weight is greater. So, and also there is greater CSF turnover in pediatric patient. So, larger doses of local anesthetic is needed for subarachnoid block. What is the result? Implications? The duration of subarachnoid block is brief with any given agent. Increased extracellular fluid volume will cause increased volume of distribution. So there is decreased peak plasma concentration after single injection, but accumulation occurs with repeat dose. Low plasma protein content in pediatric patients. What is the result? There is increased free portion of the drug, and there is greater danger of systemic toxicity. Due to increased cardiac output and heart rate in case of pediatric patient, there is increased regional blood flow. So this causes increase in systemic toxicity in pediatric patient. There is immature autonomic response, but it is advantageous. There is hemodynamic stability compared to the adult during neuraxial blockade. So fluid preloading and vasoactive agents are less important. Now, nerve fibers have less myelin. So infants and children are more sensitive to the action of the local anesthetic, providing rapid onset of action, and diluted local anesthetic produce effective blockade. Why neuraxial block is safe in children? We all know that this neuraxial blockade causes sympathetic block, but as the sympathetic system is not well developed in the neonate and infants, what happens? This fall of blood pressure due to sympathetic blockade is not seen in pediatric patients. So there is less hemodynamic instability after neuraxial anesthesia, and capacitance vessels are not well developed, so there is less peripheral pooling of fluid. Ligaments are soft, so very easy to approach. Now these are some the questions. Our beloved secretary told me that to ask the question after every 10 to 15 slides. So these are the questions. You see, what is neuraxial block? We thought we have just learned all these things now up to this time. Who first administered neuraxial block in children? What are the indications of neuraxial block in children? What are the benefits? What is the epidural and spinal blockade? Which one is commonly performed block in pediatric patients? What are the drugs used for neuraxial blockade and recommended safe dose? What are the common adjuvants used in neuraxial blockade? Mention the safe dose. What precaution you must take while performing neuraxial block in children? Why larger volume of the drug is needed in children for effective neuraxial block? And why neuraxial block is safe in children? So I have answered all the questions. So I want to see your answers in the chat box after this session. Now, how to perform different neuraxial blockade? Preparation is very important for performing neuraxial blockage in children. So, the pre-procedure evaluation is very important. There are some special consideration before performing a neuraxial block. History is very important. You have to take birth history, developmental history and immunization history and history of any coagulopathy. You have to assess cardiovascular status very carefully, any valvular lesion, any congenital cardiac defect or with fixed cardiac output state should be assessed. And examination of back is very important to see whether there is any deformity of spine or not. Now, the laboratory assessment for coagulation status, you have to go for bleeding time and coagulation time. So, you have to have good knowledge of anatomy of the child according to their age and good location of the landmark for puncture site, that you should be very careful, and you have to assess how much sensory block is needed for the particular type of surgery, and then choose your puncture site, that is location of landmark. Now, so selection of the block procedure should be based on anatomical considerations, that is, and sensory blockade of operative field, site of skin grafting or bone grafting, tourniquet or drain sites, everything should be looked for. Potential morbidity of the technique should be assessed, medical condition of the child should be assessed, the positioning is very important, and anticipated duration of the post-operative pain, whether you would like to continue the analgesia in the post-operative period or not. What are the safety measures during establishment of neuraxial block in children? The procedure should be conducted in the operating room and always apply standard ASA guideline, ASA monitoring, ECG tracing, blood pressure, temperature, respiratory rate and SpO2. Stabilize the venous access before injecting local anesthetic. You can choose proper sedation in case of children of higher age group and general anesthesia in case of lower age group and infants. All the resuscitative equipment should be kept ready. What are the equipments? Pediatrics, you have to choose proper pediatric size spinal, epidural needle, syringes, marker, select the local anesthetic. It should be diluted to desired concentration, sterile gloves, antiseptic solutions and dressings. Now, recommended devices for neuraxial blockade in children. For intrathecal and or spinal blockade, recommended devices use spinal needle 24 to 25 gauge, 50 to 100 mm long Twinkie bevel with stillet. Alternate devices, neonatal lumbar puncture needle 22 gauge, 30 to 50 mm long Whittaker spinal needle. For caudal block, use short that is 25 to 30 mm and short bevel 45-degree angulation needle with stillet. If it is not available, intravenous cannula can be used or pediatric epidural or spinal needle. For epidural block, 2A needle starting from 18 to 22 gauge you can use according to the age of the child, and this loss of resistance syringe, medium epidural catheter. Whittaker Sprotty epidural needle of appropriate size also can be used. Coming to caudal block. This is the most commonly used technique of neuraxial blockade in children. It's very simple and easy to perform. I am sure that all the students have performed it. Now, it considerably decreases the stress response to surgery. The optimum concentration of Bupivacaine is 0.125% to 0.175%, and the rate of complete or partial failure is 3 to 11%. What are the indications of caudal block? The most surgical procedures below the level of umbilicus and lower limb, mostly inguinal hernia, urinary tract surgery, orthopedic procedures on pelvic, duodenal, lower extremities. What are the contraindications? This is very important. You should know while administering caudal block. Major malformations of the sacrum, open spina bifida or infection in meningitis intracranial hypertension. In these cases, you should not go for a caudal epidural block. Now, techniques of performing single shot caudal epidural block. So, ensure adequate prevention of heat loss. The baby or the child should be covered, or the OT temperature is very important. OT temperature should not be less than 28 degrees centigrade in case of pediatric patient. Positioning is lateral decubitus with neck flexed and knee drawn up to the chest. Okay, lateral decubitus with neck flexed and knees drawn up to the chest. How to identify the landmark? This is anatomical landmark technique. Identify the posterior superior iliac spine and the sacral sacral cornus. In between the sacral cornus there is a depression. So this is the sacrococcygeal hiatus covered by the sacrococcygeal membrane. Okay, so this is the in between the sacral two sacral cornus, you just select your peak point. Now, after you just introduce the needle at 45 degree angulation first and then make it 30 degree. We feel classical pop as sacrococcygeal ligament is pierced, and you advance the needle for 2 to 4 millimeter within the caudal canal. Then you just do negative suction, aspirate, see whether any fluid or any blood is coming. If it is blood or fluid is coming, then you just reject. Do not go for caudal epidural block, and if not, then you inject the drug. Ultrasound guided needle placement is the best option for caudal epidural block in children. So how to do it? It's very easy procedure. If you practice it, you use this linear probe and identify the sacral cornu. How to identify the sacral cornu? See this picture. See this picture. So here there are two fox eye-like sign. So this is called fox eye-like sign. These are sacral cornu, and underneath it the shining structure is the sacrococcygeal membrane. So you fix your point in between the two sacral cornu, and here this is the sacral cornu, this is the puncture point. So while holding the linear probe transversely, you just fix the or decide your puncture site. Next, what to do? You just rotate the linear probe longitudinally and just introduce your needle parallel to the probe, that is, and see whether it has entered in the caudal space or not. So you can see the tip of the needle. So this is the uniqueness of USG guided block. Now, what is the volume prescription scheme of Armitage for caudal epidural block? 0.5 ml per kg for all sacral dermatomal block, 1 ml per kg for sacral and lumbar dermatomal block, and 1.25 ml per kg up to mid thoracic dermatomal block. So what are the complications of caudal block? It's very infrequent and minor. But if accidental dural puncture occurs, subsequent injection of local anesthetic lead to cardiovascular collapse and respiratory arrest. So you should be very careful while performing caudal block. Coming to epidural block. This is epidural block is administered in pediatric patient as in addition to general anesthesia. Due to less myelination, the lower concentration of local anesthetic is effective, and significant higher volume of local anesthetic is required compared with adult for the same dermatomal space. The reason I have discussed already. Now, the lumbar epidural analgesia commonly used for continuous infusion rather than single shot technique. What are the contraindications of epidural block? See here: malformation of the spine and spinal cord, intraspinal lesions or tumor, third cord syndrome, history of hydrocephalus, elevated intracranial pressure, unstable epilepsy, and previous surgery on the spine. Now this is the equipments. So if the child is more than 1 year, 18 gauge 5 cm 2V needle and 20 gauge catheter should be used. And if the child is less than 1 year, 20 gauge 5 cm 2V needle with 22 and 22 gauge catheter should be used. Techniques. The lateral decubitus position is preferred over sitting position. Midline approach is preferred below the level of L3. The reason I have discussed. Now, introduce the needle perpendicular to the plane of the block and determine the depth of the epidural space in children, that is 1 mm per kg for children more than 10 kg between 6 months to 10 years. You can detect the depth by ultrasound also. Now, how to confirm proper epidural space? Identify epidural space by loss of resistance technique using air or saline. But what is the problem with air? It can cause air embolism. So, saline is best. Hanging drop technique. If you put a drop of saline on the hub of the needle, it will be sucked in if you reach the epidural space. Why? Because the pressure is negative in the epidural space. By ultrasound guided technique, you can also identify the epidural space. The less commonly used tests are X-ray imaging in conjunction with contrasting agent, epidural stimulation test. This is rarely done. Now, aspirate the needle and ensure negative aspiration, and then the slow injection of small increment of local anesthetic as test dose. Do not introduce catheter for more than 3 cm. What will happen? It will cause coiling, buckling, knotting, all these things. And to fix the catheter properly, you can use the tunneling of the catheter. That is, the catheter is tunneled in the skin. Coming to thoracic epidural anesthesia. It is always performed before inducing general anesthesia. It is not commonly used technique in children because of the risk of spinal cord damage. So, in case of less than 1 year age, procedure is similar to lumbar approach as I have already discussed, but the needle should be introduced perpendicular to the spinous process. But for more than 1 year, it is similar to thoracic approach in an adult. Like the needle should be just introduced cephalad 45-degree angulation with the skin. The cervical epidural anesthesia is not used in pediatric patients. So, what are the usual doses and regime for epidural block in patients? For Bupivacaine and Lignocaine, for Bupivacaine and Levobupivacaine, the initial dose is, the dilution is 0.25%, and dose less than 20 kg, it is 0.75 ml per kg. 20 to 40 kg, it is 8 to 10 ml, and more than 40 kg like an adult. And for continuous infusion, the dilution is 0.125%, and for less than 4 months child, it is 0.2 mg per kg per hour. That is, it comes to about 0.15 ml per kg per hour. For 4 to 18 months, it is 0.25 mg per kg per hour. That is, comes about to 0.2 ml per kg per hour, and more than 18 months, it is 0.3 to 0.375 mg per kg per hour, about 0.3 ml per kg per hour. And for repeat injection, dilution is 0.125% to 0.25%, 0.1 to 0.3 ml per kg every 6 to 12 hours.
Ma'am, sorry to disturb you again. There has been another humming sound which has started again. Is there any electronic device which is connected to this laptop or computer, sir? Madam, because this it was slightly better till 2 minutes back. Again, that humming has started.
I don't know. I just switching off my mobile phone. Just see what happens.
Because
okay.
It is a little distracting, that sound that is coming.
What to do? Again, the sound is coming?
Yeah, it has started again. Can you mute and then unmute again?
Mute. Okay.
Mute yourself and then unmute. So now the sound has gone, but now again it has come back.
better now?
No, ma'am, the sound is still coming. It is.
Then what to do? I will unmute and just use my mobile phone.
If you can continue with the session, ma'am, if there is another system, if it is available nearby, you can then quickly log on to that system, maybe.
Okay. Just is it better?
Ma'am, that sound is still coming. That there is some problem with the speaker or your microphone, I think.
Microphone. Just wait. Is it better?
No, ma'am. I think we can continue because not getting better.
Okay, just I'm trying with another laptop. Okay.
Yes, that could be better. If somebody else is there in the meantime, we can start.
Yes.
We regret this breakage, but I think it will be good if this sound is not there, because it is slightly difficult to concentrate with this humming sound constantly coming. So, for the benefit of all listeners, uh, these lectures are live streamed on YouTube also, and the link to the YouTube I've just shared in the chat box. And more than 35 lectures have been taken by the ISA online PG classes every Monday, and all these lectures are available on the ISA NHQ channel of the YouTube. So it is actually very useful for all postgraduates, because uh, just by listening to 1.5 hour of lecture, a lot of time and a lot of doubts are also cleared. So, and these are very popular classes because a lot of postgraduates see this after their duty work is over, because many of them are not able to join now. So they join in and see these lectures offline. We had a session on neuroanesthesia earlier last time. The last two classes, there was a case discussion on airway management, and there was a class on anatomy and physiology, applied anatomy and physiology of airway management, which was also very nice. So, I mean, all listeners and all students and all postgraduates, the young faculty members, all listeners are encouraged to go to the YouTube channel and type ICA NHQ, where the whole list of all lectures can be seen and they can be accessed from there also. In the meantime, all listeners, if they have any questions, they are encouraged to type their questions and queries in the chat box itself. There have been a few queries and questions, because pediatric regional anesthesia and pediatric neuraxial anesthesia, caudal is a very, very commonly performed and very commonly asked question also. ISANHQ, Indian Society of Anesthesia National Headquarters. Dr. Srijit, yeah, ISANHQ. we're just waiting for madam to fix the sound system, because we have done approximately half an hour of this lecture, but the sound system was a little discomforting. So she's trying to fix the problem. Ma'am, can you try it out once more, just in case the humming sound is gone now? So we have a few questions in the chat box that have been asked regarding preventive and preemptive analgesia, whether they are the same. And we'll discuss all these questions after the class is over. There's another Zoom user who wishes to know if there are any contraindications of regional blocks in recently vaccinated children. So that is another question, and there is another request that we need to add a little note on the intrathecal and epidural and spinal dosages in pediatric patients, and that is by Priya Ranjan Jena. We'll discuss all these, don't worry. We'll discuss once the class is over. We will discuss all these questions. In the meantime, you can, just in case there are any other queries or questions till the time ma'am is fixing the issue, then you can just type it in the chat box. So there was a list of questions that madam had asked of all the listeners regarding pediatric regional anesthesia. And she has discussed most of the questions that she had asked already. Okay, ma'am. So I'll just. Yes, ma'am. Can you share now? Yes, ma'am. It is full screen now, and there is no humming sound also.
So I'm audible now clearly.
Yes. Perfect, perfect, ma'am. This is very nice now. I think there is no disturbance at all. I'm sorry to have.
So everything is done for the benefit of students.
Yes, I'm so sorry to have disturbed.
Not clear what is the use of this class.
Yes, ma'am. It was that humming sound was.
I don't mind anything.
A very, very nice, very beautiful lecture it is.
So probably I have left at this slide, isn't it?
Yes, yes. This is the slide.
Infusion regime for the this block in pediatric patient for epidural block. So I have discussed this slide. So you can use also Ropivacaine. The dilution is 0.2%. Okay, and the dose is same as Bupivacaine. For continuous infusion, you can use 0.1% to 0.15% to 0.2%. And the repeat dose is dilution 0.1% to 0.2%. So do not use Ropivacaine for more than 36 hours in case of infant less than 3 months. Now, what are the documented complications of epidural blockade with Bupivacaine and opioid? I have told you already that if you add opioid adjuvant to this local anesthetic, we have so many advantages. All this has been discussed. Now, so what are the complications if we use opioid with Bupivacaine? Itching, a patient may complain of itching. So if you want to avoid this, you can use clonidine. Okay. In case of nausea, you have to go for this drug 5-HT antagonist and 5-HT antagonists, that is ondansetron. Or if there is severe nausea and vomiting, though this is rare, but you can go for low dose naloxone or nalbuphine, and you also consider clonidine. There is ileus and bowel dysfunction and sedation, urinary retention. So all these are complications of the using opioid as adjuvant with Bupivacaine. How to monitor during continuous epidural anesthesia in pediatric patient? Now, every 1 hourly for first 4 hours. What are the things to be looked for? Respiratory rate, sedation score, heart rate, blood pressure. And thereafter, till the end of epidural block, you have to assess respiratory rate, heart rate 1 hourly, blood pressure and temperature 4 hourly, pain score every 1 hourly, and every 4 hourly, the sensory and motor assessment. What are the observations following a bolus of epidural infusion? If we inject a bolus of epidural, what are the things to be looked for? Again, heart rate, respiratory rate, blood pressure, every 5 minutes for 20 minutes, and pain. You have to assess pain at the same time. Now, if you want to increase the rate, you have to observe heart rate, respiratory rate, blood pressure, 1 hourly for 4 hours, and then at the same time, you have to assess pain. Again, these are the second set of questions. After some slides, what are the prerequisites for administering Neuraxial blockade in child? I have already discussed. What are the important considerations for performing Neuraxial block in children? Describe Caudal block by anatomical landmark technique and also by USG technique, which I have also discussed. What are the indications and contraindications of Caudal block? What is the volume prescription scheme of Armitage for Caudal block? This is very, very important, and you most often you are asked in the exam. How do you administer continuous lumbar epidural analgesia in a child aged 12 years, and mention the drug you want to use and mention dose? How do you confirm proper epidural space, and how do you monitor a patient after epidural block? Coming to intrathecal block. Now, intrathecal block causes differential blockade. What is differential blockade? The autonomic block is 2 segments higher than the sensory block, and sensory block is 2 segments higher than the motor block. The indications, there are limited indications in pediatric patient. They are mainly used for inguinal hernia repair, lower limb, lower abdominal surgery, but the Caudal block is very is a better option when it is used as an adjunct to general anesthetic. So, spinal intrathecal block is suitable if the length of surgery is less than 90 minutes. Larger dose of local anesthetic is needed for intrathecal block in infants and young children. I have explained it because of high CSF volume and high CSF turnover and greater distribution of CSF in the spinal subarachnoid space in children. The significant bradycardia and hypotension, which is very common in adult, after spinal blockade is very uncommon in younger children. The reason I have already explained. Now, what is the technique of intrathecal block in children? First thing, the first important thing is prevent hypothermia during the procedure. I have already told you that OT temperature should not be less than 28 degrees centigrade. Now, so plan for concomitant use of IV sedation, inhalational general anesthesia, because to keep the child quiet, you have to use IV sedation or inhalational general anesthesia. The position is lateral position or the sitting position. You see, this is the lateral position, this is the lateral position, and this is the sitting position. And in sitting position, always avoid head flexion. Usually midline approach is preferred. Short 22 to 25 gauge spinal needle is used, and distinctive pop may not be perceived because I have already told you that ligament is very soft here. So it's very difficult. Most of the time you cannot feel the pop. What are the usual doses of local anesthetic for intrathecal block? This is very, very important. For Bupivacaine, 0.5% is used. For neonate, the dose is 0.5 to 1 milligram per kg. For infant and adolescent, it is 0.4 milligram per kg for 5 to 15 kg. And for levobupivacaine, the percentage is 0.5% levobupivacaine. For neonate, 1 milligram per kg. For infants and adolescent, it should be 0.4 milligram per kg for 5 to 15 kg. For Bupivacaine, 0.5% is used for intrathecal blockade, and dose is 1.08 milligram per kg. And in infants and adolescent, it is 0.4 milligram per kg for 5 to 15 kg. And for more than 15 kg, it is 0.3 milligram per kg. Now, testing spread of neuraxial blockade by pinprick method, the sensory blockade. You have to test for sensory blockade by pinprick and cold sensation, cold stimulus with ice or a cotton soaked in ether. And for motor blockade, you have to test for Bromage scale. What are the limitations of spinal blockade in children? It is technically difficult in neonate and infants, and the failure rate is 10 to 25%. It provides short duration of blockade and lack of residual analgesia. So you have to, if you have to continue it, you have to go for epidural analgesia with catheter. What are the complications? Hypotension and bradycardia is very uncommon, as I have told you. Transient radicular symptoms, sometimes due to nerve injury, it may result in transient radicular symptoms. Post-dural puncture headache, this is very rare in children, less than 8 years. Coming to combined spinal epidural block. It is used when maximum duration, why it is used? Maximum duration of spinal anesthesia, as I have told you, neonate and infant, 75 to 90 minutes. So if you use combining spinal with epidural, the time limitation is avoided. That is, we can prolong the duration of the block. So the advantage is combining advantage of both the techniques and at the same time avoiding the adverse effects of the both techniques. Now, the indications are elective major upper abdominal surgery in awake or sedated neonates and infants and older children as an alternative to general anesthesia with caution. Now, combined spinal epidural anesthesia, this is the kit, epidural combined spinal epidural kit, and you can go for double space technique or single space technique. Complications of neuraxial blockade. The local complications are damage to nerves surrounding anatomical structure. This sometimes there's compressive tumor at the spinal canal can occur due to introduction of the epithelial cells, bacterial contamination, and after epidural blockade, there may be backache. Systemic complications due to accidental intravenous injection. Sometimes it can occur due to excessive dosing. It's rare. increased free fraction of the drug in pediatric patients. So these are the three causes why there is systemic complications. The manifestations are neurologic manifestations are tinnitus, malaise, metallic taste in mouth. But they are often masked by general anesthesia because we are using this as an adjunct to general anesthesia. So if the patient is under general anesthesia, it is very difficult to detect all these things. Cardiac symptoms, cardiac arrhythmia can occur, radiant tachyarrhythmia. There is on ECG, you can see QRS widening, ventricular fibrillation, sometimes asystole is the dangerous observation. Now, how to manage the systemic toxicity? Early identification of symptoms and signs, very, very important. And the one thing in children is cardiovascular complications are concomitant with cerebral toxicity. Now, what is the treatment then? The protective measures should be just followed, that is airway, breathing and circulation, oxygenation, cardiac massage, epinephrine 1 to 2 mics per kg, low dose is used. And in case of ventricular fibrillation, you have to defibrillate with 2 to 4 joule per kg. The specific treatment is 20% intralipid. It's very, very important. What is the dose of intralipid? 1 to 1.5 ml per kg IV over 1 minute. And then repeated every 3 to 5 minutes during resuscitation up to 3 ml per kg. On evidence of recovery, the infusion should be started at 0.25 to 0.5 ml per kg per minute till 10 minutes after hemodynamic stability is attained. Hemodynamic effects I have already discussed, uncommon in pediatric patient. Total spinal blockade can occur. Hypotension should raise suspicion of total spinal anesthesia and intravascular injection of local anesthetics. What are the contraindications of the neuraxial block in children? The absolute contraindication is parental refusal, known allergy to the local anesthetic, and relative contraindications are severe coagulation disorder, constitutional like hemophilia, acquired DIC, that is disseminated intravascular coagulation, and in case of therapeutic contraindications are severe infections, intracranial tumor, certain chemotherapy, cisplatin-induced subclinical neurological lesions. So you have to document if the patient is on chemotherapy, and then you can go for intrathecal blockade, but in case of cisplatin, it is relative contraindication. Uncorrected hypovolemia, cutaneous and subcutaneous lesions at the contemplated site of puncture, and pre-existing neurological disease. In this case, this is you should not go for neuraxial blockade, but this is relative contraindication. Here are the questions of the third part. How do you position the baby for intrathecal block? Why larger dose of local anesthetic is needed for intrathecal block in pediatric patient? How do you perform the intrathecal block in neonate? Is it safe in neonate? What is the usual dose of local anesthetic for spinal anesthesia? What are the indications and contraindications? What is the advantage of CACA technique? And how do you diagnose last and manage it? What is the dose of intralipid in pediatric patient? So the take-home message: pediatric neuraxial block is safe. It is the most commonly used block. The most commonly used block is the Caudal block. And USC guided Caudal block is safest. Caudal block is administered as an adjunct to general anesthesia. There is less hemodynamic instability compared to adult in case of neuraxial blockade in children. Local anesthetic drugs should be administered according to dose mentioned in the guideline. Chance of local anesthetic systemic toxicity is higher in children. Can be detected late under general anesthesia, but judicious monitoring is mandatory, and that will lead to a safe and successful outcome of a neuraxial blockade in children. So thank you. These are the references.
So thank you so much, ma'am. And that was a very comprehensive lecture on the pediatric neuraxial blocks. I think the questions that you have
Yes.
asked and the questions that you have set, all the postgraduates should note it down. And if they are able to answer all those questions, then the chapter and the concerns with pediatric neuraxial blocks will be over. So once again, a very heartfelt gratitude, madam, for this wonderful lecture. And there are certain questions there in the chat box.
Yes.
With your permission, ma'am, if you are ready, then we can just discuss then.
Yes.
What we will do is, once our discussion is over, then we will allow everybody else to unmute themselves, and then they can ask the questions themselves. They can interact with their questions or whatever comments they might be having. They share their experiences also.
Okay.
So if you allow, ma'am, should we start the question answers, ma'am?
Yes, yes.
Okay, so the first question was for by Dr. Saurabh, and he wants to know about whether preventive and preemptive analgesia are the same.
No.
Yeah.
Preemptive analgesia is administered before the neuroendocrine response, that is the surgical incision. Okay. So preemptive analgesia should be administered prior to this neuroendocrine response, that is surgical incision. But preventive analgesia, it should be started in the preoperative period, continued through intra and post-operative period. Okay. And for preemptive analgesia, you can use this. Mostly we use is intravenous analgesics, whereas for preventive analgesia, most commonly epidural catheter is used. Epidural analgesia is used.
Right, ma'am.
Okay.
So there is another question by a doctor who has come with the name of Zoom user. If there are any contraindications to regional block in recently vaccinated children.
Recently vaccinated children. If the coagulation profile is normal, you can go ahead. No problem.
Yes. I mean, for regional anesthesia specifically, because then the concerns with vaccination is the pain and swelling, and anesthesia we know reduces the anesthesia. Stress and trauma are known to suppress the immune system, but there are no clear-cut guidelines in which whether we should go in for.
One thing
yes.
is regional blockade. Regional blockage is not detrimental for immune system.
Yes, yes.
Enhances immune system.
Yes. Okay. So I think we can. There should not be a problem there.
Yes. But you have to check the coagulation profile.
Right. So, Dr. Manasa wants to.
I can open the chat box. What is the problem?
Yes, Dr. Manasa wants to wanted you to add a little note on the intrathecal, epidural, and spinal dosages in pediatric patients, which I believe you have done in the tables.
Yes, that I have taken from Smith's textbook of anesthesia for pediatrics. Okay.
Right.
You just go through it. This book, Smith's pediatric anesthesia. Then you will find all these tables. I have taken these tables from that book.
So, Dr. Priyaranjan Jana also wants to know whether in pediatric patients for lower limb surgeries, which one would be better, caudal block or spinal anesthesia?
Caudal block, no doubt about this. Caudal is so safe. No, intrathecal block, if you just inadvertently just go above L3, what will happen? It may directly injure the spinal cord. So caudal is always safe. Okay, there is no risk of injury, direct injury to the nerves.
Right, ma'am. So, Dr. Apurva Naveen wants to know what is the sign in ultrasound appearance of caudal epidural space? That ultrasound sonographic appearance. If you could show the slide, ma'am.
Yes, I'm showing the slides. It's very important. We are now using ultrasound, and it's very easy in pediatric patient. So you use this linear probe, okay, and you just identify the first by anatomical landmark, you first identify the sacral cornu and then hold the this linear probe transversely. Okay, to identify this, these are the sacral cornu. They look like this frog's eye. Eyes of a frog. So you identify this part, this frog's eye appearance, and underneath this is the shining structure. This is sacrococcygeal membrane. So in between this two sacral cornu, you identify the midpoint and you fix your prick point there. You fix your prick point there. And next, what to do? You rotate your this linear probe longitudinally and introduce the needle parallelly to this probe and see this, whether the needle is entering the epidural space. If you go further, you will not see anything because of this acoustic shadow. So this is the difference why fluoroscope is preferred than caudal. That is a separate issue. So don't confuse all these things. So you identify the tip of the needle by USG and identify the space. This is the uniqueness of using USG for caudal epidural block. Then anatomical landmark. Okay, clear now? Is it clear?
I think it should be clear. I mean, this is very well explained. Yeah, I think he was wanting to know about the frog's eye appearance, probably Apurva.
Yes.
In any case, we will allow them to unmute themselves after the discussion, ma'am, so that if there are any other doubts, he might ask.
Okay.
So, Dr. Shaista Tabassum also has a question regarding the dose in children who are less than 5 kilos and more than 15 kilos for Bupivacaine dose for spinal anesthesia.
I have mentioned all these things. Go through my slides, you can see. Or you consult the Smith's textbook for pediatrics. There, everything is written. I have taken all these things, these tables from that book. Okay.
Yes, ma'am. And another question she has is that whether cisplatin chemotherapy is contraindicated for intrathecal blocks in adults also.
Cisplatin is the problem is it should better to avoid this Neuraxial blockade if the patient is on cisplatin. And the reason I have told it is the same as for adult. Okay.
So it is better that we avoid.
Yes, we avoid. Yes, I have written this. The subclinical neurological lesions are there. So if you have to document it, otherwise you can't go ahead, isn't it? If the patient is on cisplatin, as it may induce subclinical neurological lesions, and if the patient after administering Neuraxial blockade develops subclinical neurological lesions, you cannot identify whether it is due to cisplatin or due to your block. So you have to document, okay? Otherwise, you may have to face the court, okay?
Right, ma'am, right. And regarding hemophilia, Apurva Naveen wants to know whether hemophilia is a relative contraindication to central neuraxial block or is it an absolute contraindication?
I have taken this from this book. This I just read this guidelines for pediatric regional anesthesia. So they have written, but it is really questionable whether in hemophilia you go for this Neuraxial blockade. It is relative contraindication or an absolute contraindication. Better not to use the Neuraxial blockade.
Also for severe coagulation disorders.
Yes.
The one before it.
But constitutional hemophilia is a different thing. Sometimes, most of the time, it is stable. You can go, but better to avoid. Relative contraindication they have mentioned, but better to avoid Neuraxial blockade in hemophilia patient.
Dr. Saurav wants a practical how to relieve anxiety in pediatric patients to be operated under plain spinal anesthesia or epidural block as a sole anesthetic technique. How to relieve anxiety in pediatric patients?
you are using it as sole anesthetic technique, epidural block, isn't it?
That is what his question is, whether we should give it for anxiety.
Yes, in older children, you can go for it, but usually the pediatric patient has fear of needle prick. Okay, so before starting, before this Neuraxial block, before administering Neuraxial block, you have to start an IV line and they may refuse. So to relieve anxiety, it's better to use inhalation agent or sedation. Or you can apply also to start an IV line. You can apply for an EMLA cream or go for inhalation anesthesia and then go ahead for this Neuraxial blockade. Clear?
So some form of sedation would be recommended.
Yes, you can give midazolam. It is the best. You can also use nasal dexmedetomidine. We have used it with very high success rate, 2 to 3 mics per kg. And if you use nasal dexmed, they will allow it to do an IV line, and also you can administer this Caudal block. So you can use nasal dexmed. It's very good, dexmedetomidine.
I think it will also depend on the age of the child.
Yes,
a little elder.
not in lower age group. Because they always have needle fear. They will not allow it.
So Dr. Manoj wants to know about the Neuraxial blockade of choice in premature infants. What would be the drug and dosage of choice? Drug of choice and the dosage.
Neuraxial blockade. What type of Neuraxial blockade? You can go for Caudal epidural block. This is the safe for this premature infant, and I have mentioned the dose, isn't it? You can try with Bupivacaine. You can try with Bupivacaine, Ropivacaine. Okay, and you can also use adjuvant for Caudal epidural. But for premature infant, better not to just go for spinal, that is intrathecal block, and also for this epidural blockade, lumbar epidural blockade, because the result you want to achieve can be achieved by Caudal block.
Caudal. So Caudal would be preferable in such patients.
Yes.
So how to assess the modified bromage or level or the level achieved if the patient has been sedated or anesthetized while giving, I believe, the spinal anesthesia in children, let's say.
This is a very good question. Okay, so how to assess this bromage and also this sensory blockade, isn't it? So what do you have to do? You just under inhalation anesthesia, if you use inhalation anesthesia, there is this muscle relaxation. You can test for bromage, but it may not be accurate. Okay, it may not be accurate. Because this inhalation agent will not cause much muscle relaxation, isn't it? Until and unless you use sevoflurane. Okay.
So if the child is sedated, how will we assess the bromage, ma'am?
If the child is sedated, it can be arousable. Sedation means
arousable.
Yes, not deeply sedated. The patient can be arousable, isn't it?
Okay.
So they can respond to. They can respond easily to this needle prick, and also they can you can test for bromage, but with difficulty. But you can test sensory blockade, no doubt about this. The child must be arousable, sedated but arousable. Okay.
So I believe there are no further questions.
Conscious sedation. When anesthesia is used, you have to go for conscious sedation, not deep sedation. Okay.
So there are no more questions in the chat box itself, ma'am. What I will do is I will allow everybody to unmute themselves. You can stop sharing, ma'am, if that is okay.
Okay. Stop sharing. Yes, stop sharing. Yes.
So all participants have been allowed to unmute themselves. Just in case there is any question or comment by any other respected member or the respected audience member, then they are most encouraged. Or if there is any question by the postgraduates who have not been who have not typed it in the chat box, or not we have not been able to frame the questions properly for them, they are requested to just ask their questions, just express their views. If there is anyone.
Everything is made clear.
Yes. Ma'am, for this session, we have Dr. Ankul Khandelwal with me, who's helping the ISA National online PG classes. Ankur, is there anything you wish to speak?
Yeah, thank you, Nishant sir, and thank you, ma'am, for this wonderful presentation. It was a very informative one. Ma'am, I have just one query. How safe is dexmedetomidine to be used as an adjuvant in regional blocks for pediatrics?
As in Smith's anesthesia, it has been mentioned that you can use clonidine. So dexmedetomidine is also safe. Okay, and I think there are the literatures are there for support of this. Okay, so it's safe. Previously, this 5 to 6 years back, it was not in 2013 when we are using nasal dexmed. It was not recommended by FDA. But after that, FDA recommended this thing for adult, and also I think as clonidine, you can clonidine is advisable, so you can use also dexmedetomidine. And as procedural sedation, it is unique.
Okay, thank you so much. Because as far as I remember, dexmedetomidine is still not yet approved for use in pediatrics, even though off-label studies are being done. And not many studies have been published, but I'm not very much aware whether it has been actually approved by FDA in recent times or not.
Okay, I have not seen this. I have not seen the recent literature on dexmed, but in adult it is advisable. But in pediatrics, yes, they are just advising clonidine. But dexmedetomidine has not come in the literature in recent days. Yes.
Thank you so much, ma'am.
Okay.
So, with no more questions in the chat box and not.
One thing, Dr. Ankur.
Yes, ma'am, please.
Yes. Have you seen any literature or against this dexmedetomidine use in pediatrics?
No, ma'am. There are abundant literatures of which has shown the off-label use of dexmedetomidine, but again, as far as I remember, it has not been FDA approved.
Yes.
Even though there are not many studies.
Yes, nasal and oral dexmed is FDA approved, not this thing. Yes. Thank you.
We'll just maybe we'll be able to check that out. So thank you so much, madam. It has been a wonderful lecture, and most of the questions that will be asked of the postgraduates and most of the doubts that the young faculty, even the people who are practicing pediatric anesthesia, most of the doubts must have been cleared by the talk and the wonderfully elaborate lecture that you have had regarding all the doses and all the techniques. Once more, sir, ma'am, we are very grateful for the time you have taken out for this ISA online PG class, and we thank all the listeners.
Sir, can I have just one more query?
Yes, doctor.
Ma'am, do we routinely put a epidural caudal catheter?
No.
Caudal catheter.
No. We most of the time we use single shot technique. No, not epidural catheter.
Caudal catheter we are not using.
No, not caudal catheters. No, single shot caudal block.
Okay, ma'am. Thank you so much.
And USG is the best. You try and use it. I am sure that you are using it.
Yes, ma'am. The frog sign which you showed, it would be very beneficial for all the delegates here. Yes. Thank you so much.
Yes, at our center we are using sometimes, ma'am, caudal catheters also.
Okay.
Sometimes we are using, and that tunneling technique is very useful for the caudal catheters because the area gets soiled in children. So we do that also sometimes. Okay. So thank you so much. And if there is no other question, there is one question by Dr. Saikat Nyogi, pediatric brachial. Dr. Saikat, you can unmute yourself and just express yourself. Pediatric brachial blocks. So that is very commonly given.
Hello.
Yes, Dr. Saikat.
Madam,
yes.
if in operation in upper extremity, and we have to give in the brachial block, which route is preferable?
Which route for brachial block? Which route?
Yes, whether supraclavicular or axillary.
It
Or-
depends on the surgery. Okay, it depends on the surgery. Okay, so if it
Okay.
is on the wrist, you can go for axillary block. Why brachial block? You have USG and go for axillary block. Okay, so but if this upper part, suppose a plate is there in the upper arm, then you have to go for this intercostal brachial block, intercostal brachial nerve block. So you have to go for sometimes this supraclavicular brachial plexus also fails, and you have to go for interscalene. So this depends, all this depends on the type of surgery or which surgery, for which surgery you are using the block. So it is very important to choose the block according to the surgery. You have to block all the nerves, okay?
Okay. And then which drug is preferable, either Ropivacaine or Bupivacaine?
Oh, which drug? Which
Yes.
drug is preferable?
Mm.
If you are using it as an adjunct to general anesthesia, then Ropivacaine or Bupivacaine. Why Bupivacaine has so many complications, and you have to use larger dose. In pediatric patients, they are very prone to develop local anesthetic systemic toxicity. So use Ropivacaine or Bupivacaine in that case.
Okay. Thank you, madam.
And one more thing I would like to add, because I'm mostly confined to neurosurgical theaters, I'm routinely using scalp blocks in pediatrics for
Yes,
post-operative
scalp block
pain
is very safe. Scalp block is
Yes.
very safe.
management.
Dr. Soikat Nyogi is also using scalp block because he is working in our college. He is working in neuro-OT. So he is
Okay.
very frequently is using scalp block.
Yes.
ma'am.
Yes, madam.
Oh, thank you, ma'am. Thank you so much for your time and effort, and much appreciated, ma'am. And with this, if you allow, we can take the leave. Thank you for this elaborate lecture.
Welcome.
Thank you so much, ma'am.
Thank you, Dr. Nabin. Thank you, Dr. Ankur. Thank you, Dr. Sahar. You have helped a lot and allow me to complete my lecture.
Yes. Thank you so much.